Since we're such a small group, if you have a question that's like you're dying to ask, just put your hand up. I'm very interruptible, thankfully for my ADHD. But I wanted to tell you a little bit about Less Cancer before we start. Less Cancer's official name is Next Generation Choices Foundation, a huge mouthful. And when we started it almost 23 years ago, by the time I got it out of my mouth, the next funder was like, listen, you got to either speak faster or come up with a better elevator speech. So we are known as lesscancer.org. We are founders of National Cancer Prevention Day, the National Cancer Prevention Workshop, and the United States Bipartisan Congressional Cancer Prevention Caucus, blah, 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 blah. So basically, we are an education organization. Today's CMEs will be coming from Michigan State. And we educate everyone from healthcare providers to leaders in communities that will include legislators. So public health is a little complicated because we don't understand. It's not like a linear shot to the arm, Band-Aid to the skin kind of conversation. It's complex. It's all encompassing. It's a huge, huge umbrella, big conversation. And we, in short, are really about public health and securing systems that help lower risk. And for me personally, which, by the way, I'm a C student from Wayne State. I'm not a physician. I'm not a healthcare provider or a scientist, but I'm surrounded by brainiacs, thankfully, and they'll tap me on the shoulder anytime we need some support or guidance. And we're so lucky to have that. So we work on a lot of systems that help to lower risk, and that's really a public health model. Some people get confused that possibly wellness steps, which are important for all of us if you can do it, but the wellness steps are different than public health. They're different than systems that help provide access or connect people to care and lower risk. So does anybody have any questions about that? Anything that we're doing? All right. So Kelly Herco, right here, is Dr. Kelly Herco, and she has been a friend to Less Cancer for a super long time. And you've done 2 or 3 workshops, you've come to DC, and you've been part of important conversations with very diverse crowds and diverse legislators. Everything we do, you know, especially on Capitol Hill, if we have one of one flavor, we make sure we have one of another flavor. So public health, less cancer, prevention is for everyone. So we are very inclusive on that way. Can you tell us a little bit about what you do?
Sure. Hi, everybody. I think I know many of you in the room, but my name's Kelly Herco. I'm a community-based researcher here at Munson. But I'm employed by Michigan State. I'm an assistant professor in the Department of Epidemiology and Biostatistics at Michigan State. And most of my research focuses on cancer epidemiology, so the trends and patterns in cancer, particularly interested in modifiable factors and how those might lead to some of the disparities that we see. So a lot of the work that I do tries to address rural cancer disparities in my role here.
So let's just open the conversation with how the environment, air, water, housing, and the place-based factors impact our health. Can you share a little bit about that?
Yeah, I'm happy to. I can talk about my experiences as a community-based researcher. Most of the research that I've done has focused more on lifestyle factors and cancer risk. And most of the research I've done has focused on breast cancer particularly. But in coming to a community-based position, I try to address the needs of the community or understand what are the priorities and the cancer concerns in the community. And one of the first things that I heard about when I came to Traverse City in 2016 in this role was concern about the high incidence of breast cancer in Grand Traverse County. At that time, it was the highest in the state of Michigan. It's no longer the highest, but there was a lot of concern about the pesticides in the region and the cherry orchards. And so we tried to do some research into that. So I'll speak about, what I've learned in that process, but I'm by no means an expert in environmental exposures. It's very complicated to link environmental toxins to cancer because we have people that move throughout their lifetime. We have critical periods of exposure where, especially in breast cancer, there's a critical window between first period and first childbirth that seems to be really important in how those exposures later impact your breast cancer risk. So it's a little bit tricky to investigate in epidemiologic research. But we do have a lot of evidence about the properties of pesticides, for example, on endocrine disruption pathways. So there's a biological plausibility of how these exposures might impact breast cancer. When we look at environmental factors overall, they're more strongly linked to bladder cancers and blood cancers, leukemia, lymphomas. And a lot of the work that we've done in the medical field or epidemiological research has focused on agricultural workers. So it's, these high exposure categories. So we have a lot to learn in the field of environmental exposures and how those impact cancer. I think there's biological plausibility for a lot of it. There's evidence from mouse models, but not a lot in humans other than.
Can I just point something out here? When people are listening to this, because people are like, oh, does this cause this? Because we hear from a lot of people. I don't think people really understand the difference between like a correlation and a causation. And I'm wondering if maybe you could unfold that a little bit relative to that.
Yeah, I mean, one example of that is when I first was digging into the breast cancer incidence rates in Grand Traverse County, there was a lot of concern about particular regions of the Old Mission Peninsula and how there was seemingly higher rates of breast cancer in areas of the peninsula that are also agricultural, have vineyards and perhaps higher pesticide exposure. So people, were thinking that this pesticide is causing the breast cancer rates that are higher on the peninsula that we keep hearing about. But when we actually mapped out, we were able to get breast cancer data on residential addresses for 2 years of breast cancer cases at Munson, and we looked at the census tract level of the number of cases divided by the number of women in that census tract over 18. And then we overlaid it with agricultural land that was zoned agriculturally. You could see that there was this overlay in the Old Mission Peninsula where there was agriculturally zoned land, which would purportedly have higher pesticides and a higher burden of breast cancer. But then there were also regions in other parts of the counties that had high agricultural land and didn't have the high breast cancer rates, and vice versa, areas that had higher rates of breast cancer, but not the agricultural land, right? So that is an example of it's correlated. Perhaps in that region, you see that it might be a factor, but then is it a causal factor? Because if it was a causal factor, especially as an epidemiologist, you have to have strong, consistent evidence of this factor is leading to the development of disease. And we don't necessarily have that. You need a dose response, you need consistent evidence. We don't have that yet. So correlation is more this thing might be associated, but to say something is a causal agent is very difficult to do with epidemiology.
No, and we may not. I mean, this is where like unnecessary and preventable exposures come in. If we don't know the full story, that doesn't necessarily mean it's good to go, right? So we know that there's harm in some of these things, and also too, it's important to point out when people were using a lot of these chemicals in the 30s and the 40s and 50s, those were people who were operating with very little knowledge about outcomes, so they were unintended consequences. And so that's a little bit different than some of the things you'll read about, like the movie Dark Waters, where a company was dumping chemicals into the water and they knowingly did that. So it's a little bit different, but it is because there's a lot going on here. You also work with social structures as well. And could you just touch down on that a little bit?
Yeah, a lot of the work that I do tries to address cancer disparities and try to understand what we can do in our systems or in our lifestyles that can address those factors. And so I know that, a lot of these lifestyle factors that we hear about, like tobacco use and obesity, are contributing to a lot of the cancer disparities that we see in rural areas. And if you think about the drivers of those, if you look at tobacco outlet density in rural areas or in low income areas, if you think about availability of places to exercise. I mean, Traverse City, we're no longer rural, so I guess I can't talk about it as a rural county because as of 2023, Grand Traverse County is no longer considered rural. But, it used to be kind of an exception. We had amazing physical activity opportunities in general in our city with the TART trails and outdoor recreational opportunities. But in many rural areas, people live in places that they don't have sidewalks. They're not really conducive to exercising. They'd have to drive a long distance to come to a gym facility. So there are these kind of structures in our environment that impact these lifestyle factors and our ability to be exposed to cancer risk factors. For example, environmental toxins at Superfund sites. There are, structural policies and practices in place that make it so that the people that live closer to some of those environmental exposures are lower income or more disadvantaged.
I hear you. I just wanted to add to this point of no longer being a rural community that Traverse City has a lot of rural neighbors. And so as a result, the pull on this hospital, this community from the rural neighbors that are underserved is significant. And I'm not sure that's much of a conversation now. Maybe it is, but it's something that already, struck me. I know that there are people here, and Dr. Word, who we're moving on to next, can tell us a little bit about the people that come great distances to get treatment here. And many do. And distance too is a health disparity as so many other things. If it's okay, can we move on to Dr. Word? And can you tell us a little bit about yourself? And
Sure. Zachary Hector Word is my full name. I'm medical oncologist here at Munson. I've been here about 12 years now. Came immediately after finishing my fellowship in New York, and I've been practicing general medical oncology here at Munson in Northern Michigan, for that time.
And doing a great job.
Oh, well, thank you.
Can you tell us, this isn't really part of what I want to talk to you about, but do you have any firsthand information of some of the patients that are coming great distances here? What's that look like?
Well, I see some of them. I mean, as you know, it's a mix. Obviously, we have patients from right here in town. Until you get south to about Grand Rapids, there's not much else.
Right.
And going north, there's docs in Marquette across the bridge, and there's some docs in Petoskey. I mean, there's some resources to the north of us. Mm-hmm. I know Dr. Michelin, who does gynecologic oncology, probably sees the biggest catchment area because he's one of the only gynecologic oncologists in the area. We generally don't see that many people from the UP, but a few, and we see it's still a pretty big area. I
Had somebody a couple of years ago that told me they drove, well over 100 miles to get here.
Yeah.
I found that startling. Stuck with me. It's like, wow.
Right. Yeah. And in the winter, it's even harder, right?
It's terrible.
The roads can be bad.
It's terrible. So can we talk a little bit about screenings, and can you tell us about the importance of screenings relative to survivorship outcomes?
Yeah, sure. So, I think this has been well publicized, and American Cancer Society and others have, I think, done a good job of getting people in general aware of the basic concepts behind cancer screening. But most solid tumors start out with a cell becoming cancerous. It grows, it divides, it becomes a tumor. And in the model where we think of it, it eventually gets to the point where it starts spreading, usually first to the lymph nodes in many cancers, and eventually will spread. It'll grow. That tumor might grow big enough that it grows into other tissues around that area, which can make it harder to remove a tumor like that. And it can also spread through the blood to other organs, which is generally the definition of stage 4 disease, which we generally think of as incurable. And so in terms of prevention, obviously, if you're finding a cancer and treating it, you're not totally preventing it because it still happens. But the hope is that we can prevent that stage 4 metastatic disease, because that's the point where it most often becomes incurable. And so screenings are intended to find cancers at an earlier stage so that they'll have a higher chance of being curable at the time that they're found.
Well, and two, you're often preventing metastatic cancers in different parts of the body. So at one level, it's very preventative.
Right.
A lot of smoke in the air here.
Yeah.
And so, what are the challenges that you hear in your offices about people getting screened? Like, what do they say to you? Is there something that you could share on that level?
I think that gets a little bit back to our rural environment. The biggest complaint is just that it takes longer than people would like, right? I mean, somebody has a symptom and needs to get it investigated. I think in Traverse City and certainly Cadillac and some of our communities, we do have a pretty good primary care group, and most people do have a primary care provider, but not everybody does. And often the people who don't are the ones who fall most into that underserved category. And so somebody has a symptom, sometimes they first have to get themselves a doctor, then they have to get an appointment with that doctor, then they have to get referred to another doctor to get the actual screening that they need. There can be delays in multiple stages along this, and so trying to speed that up, I think, would be the thing that would help the most, because it's obviously a scary position to be in. I don't know, I may not have reminded me of your question.
Yeah, well, I have something else I want to add to that. I wanted to, we don't often talk about survivorship or support, and I'm curious about how that fits into, because the stress of the disease certainly adds to the overall health. And, and survivorship and those support mechanisms are important. And possibly important for lowering risk for more cancer. So,
yeah, absolutely.
Could you share anything on that front?
Yeah, so in terms of survivorship, I mean, we define a cancer survivor as anybody who's been diagnosed with cancer and is alive. So it kind of starts at the time of diagnosis in terms of survivorship. We tend to think about it often in terms of patients who have had a cancer, often a curable cancer, and it's been treated. And sometimes our focus shifts to survivorship. But, having cancer can have all kinds of effects in terms of the symptoms of the cancer, in terms of psychological effects of knowing that you have cancer. Sometimes you have to continue to undergo screenings for a long time, and that can be very anxiety provoking. There can be physical symptoms that result from the treatment and psychological effects that can result from the treatment. So there's a lot of symptoms and problems that can result from both the disease and from the treatment of the disease, and those can go on long after the treatment is completed, but they can also start pretty early after the cancer is diagnosed. So cancer is very much a disease that requires a team approach to management. The two specialties that sort of focus solely on cancer are medical oncology and radiation oncology. But it can affect, every part of the body, and there's lots of other specialists and primary care docs and other healthcare providers that play a big role in managing all of those things and helping to manage all those things.
Just to add here for a second, when I had first understood that survivorship meant anybody that was alive, literally quite alive, to me, because I'm so literal, I was like, wait a minute, this guy doesn't look like he's surviving. He doesn't look like he's here for long. So that was always a little confusing for me. And then somebody explained, well, we refer to this as survivorship in honor of their journey, in honor of what they're going through, and, of a continuum, which gave me a greater understanding.
Sure.
But we know that when cancer organizations, not some, talk about, X millions of survivors in the country, that's true. But I think the general public doesn't really understand that's anybody with a cancer diagnosis that's alive. And that's a little bit different than understanding. I don't know if there's a better way of explaining it, but for me, it wasn't very clear in the beginning. And so that's why, they're survivors, but I don't think the general public really has an understanding of what that looks like necessarily. And so I just wanted to point that out because I thought it was interesting. The American Cancer Society this year before, said prevention is really the reason we're having so many good outcomes for good survivors that are highly functioning. And that was good to hear. When we first initiated Less Cancer a couple decades ago, we were thinking we could possibly lower the incidence of cancer. That has not been the case. But what we do know is that some of the things that we're educating communities on is that it's really extended and made lives much better.
Yeah.
And in some cases cured people. So
that's
all good news. And we so appreciate your work.
Thank you.
Dr. Word trained at Memorial Sloan Kettering, which is my hospital, and I love that place. And so I think you're all very lucky to have him here. They've done amazing things in my world and for other people. So anyway, Tricia, can we move on to you? Is that okay? Tricia Petzold has a couple roles with us, not just as an educator, but she's a physician in Salt Lake City, Utah, went to Georgetown, and is the chairwoman of Less Cancer. And so we're so grateful for your work, but I was wondering if you could tell our community here a little bit about yourself.
Thank you. Thanks for having me here. I think it's just an honor and a delight for me to spend time in Traverse City. So I'm thank you for being here and having this and inviting me, Bill. So I trained as a family physician, and I've been, really spent most of my career as an emergency room physician, because that's what we did back before emergency medicine residencies were common for more rural areas. And maybe 2018 transitioned to more integrative health, looking for root cause of disease and whole person health. And with that, transition to teaching at the University of Utah in the med school and trying to help future physicians understand the whole person. And with that, I direct a 4-year curriculum as an elective, where you can come into med school and learn how not only the diseases and how to treat them, but how to prevent them and think about the whole person. Is called Health Promotion Integrative Health, and we really teach it from a point of view of how do you build resilience as a human being, meaning the future physician as the human being. Because when you do certain things that help you be more resilient and healthy, you're more likely to share them with your patients. And some of those studies have panned out. So that's sort of the basis of the curriculum. And then we've collaborated with many universities across the country on teaching kitchen collaborative and culinary medicine and using food as medicine. So really taking one of the lifestyle factors that has a big impact on disease, and helping students know how to understand how to apply the little bit of nutrition they get in medical school education in a real practical way, clinical way.
That's great. We love your work, but it's also challenging to get when we talk about health disparities and those people that don't have access or don't have the options that many people have is bridging the gap there to get, those those services, that education to a population where it may not be as easily accessible in their own world to lower risk. And one example, I was speaking in Highland Park, Michigan, not all that long ago, and there was a group of unhoused ladies that were in this group, and I happened to say to this woman, I was telling them about the Capuchin Soup Kitchen, which raises all this like urban garden food. They have great services. They refer to their guests as guests. It's filled with integrity. The whole place is great. So, and there happened to be a Popeyes across the street. And I said, anybody here eat at the Capuchin Soup Kitchen? And they're like, nah, not really. I was like, well, who eats at Popeyes? And because I'm thinking, here I am with like falling out of a privilege tree, thinking, who would eat at Popeyes? And this woman raises my hand and she said, I just want you to know that we eat at Popeyes when we can afford it. Her and her children live in a shelter because it's the only thing that lets our kids feel normal. It's heartbreaking that would even be a reason, but it makes sense because we're so into this heavy marketing of fast foods and all this like easy looking fun stuff. And, a 6-year-old isn't interested in health. They just want to be cool, like the guy on TV or on the radio or wherever they're getting their media from. So it really, I think my point in sharing this is that your science is so critical for lowering risk, but our challenges as an organization are finding roads so people can have access to what Dr. Petzold is teaching. You know what I'm saying? And that is an ongoing transition challenge, not just a transition, but ongoing challenge. So is there anything you'd like to add to that, Tricia?
Yeah, I think your point of changing the conversation of having, and it's changing the conversation so that people understand, and I guess changing the conversation, what I mean is right now, most most people don't hear from the physicians the importance of nutrition in a certain disease that they have or they're trying to prevent. And so, because a lot of times we say we don't have enough time, we have to really focus on the medicines they need, or we have to, the time we have with the patient is so focused on something other. But there have been studies that if we bring it up for 3 or 4 minutes, physical activity, for example, 6 months later, those patients who were asked inquisitively by their physician, what do you do for physical activity, and given 1 or 2 pieces of advice, are more physically active than those who didn't get that exposure. And so I think the same thing happens with nutrition, and having various awareness of the value of that as the provider, changing the conversation with the patients, and then having it accessible to the people, in having it tied into our EMR, our electronic medical record, so it's easy to remember and to use, and then having either handouts or texts or electronic handouts or whatever that are culturally appropriate, educationally appropriate, accessible. And I think and I think also that curiosity, why is this person eating at Popeyes and why aren't they utilizing this local resource we know about? 1, do I know about it as a physician and can I share it? And 2, do they know about it? Is it socially acceptable for them? If it's not, then how do I break down that barrier?
It's a big challenge. It's a really big challenge, and it is. And I think, one thing I know, because I've seen Dr. Petzold in action, is that it's really providing strategies. Like, it's one thing to say spinach does X, Y, and Z for you. It's another thing to be able to say, where do you get the spinach? How do you get it? And maybe give little tips. And the whole message might not be heard or absorbed. We can't tell that. But what, as you pointed out, there is science that when that conversation occurs, the risks go down. They walk away with information. And so in public health, we use a lot of social media and regular conventional media to translate messages, and we see that it works. We know, we have the information and the demographics to know that when these conversations happen, the risk goes down. People are empowered with more tools to move forward with the right information. Quickly, Tricia, can you let me know if there are first steps that you give to patients to just, how do you light that fire? Like, what's the first step you can tell a patient?
Yeah, it's a good question. I think in general, we think about simple, sustainable changes. So we know there's things like add a vegetable a day. And so if someone's not eating, basically we know that nutrient dense, plant-based, plant-forward foods have a lot of benefits, health benefits, and reduce inflammation, reduce oxidative stress, can prevent diseases, and also help people be healthier, so the treatments work better on disease. So we would kind of think of it in that way, and when we being curious, finding out where they're starting from. Can we reduce highly processed, ultra processed foods? Can we add a vegetable? Can we reduce processed or red meats if they're eating it 14 times a week? Can you think about meatless Monday or replacing one meal at a time? And I think in general that when we do a small thing and we sustain it over weeks to months to a year, it makes a huge impact on our health. So trying to help people meet them where they are and make something and not scare them too badly to get them to get started. Now I say that, and that's how we teach it, and that's what we do. But I have what I feel is a really powerful tool that I've been using for 5 years now, and I've seen huge shifts in health. And what I'll do is a group visit model where I'll get 20 people together, and for two months we will go through a process of really eating in a low inflammatory way. Lots of nuts, seeds, herbs, spices, plant-based foods, and really see how people can experience for 21 days how they feel from the beginning to the end, and have that in a community setting so people are connecting with each other, connecting with their food, and connecting them with themselves and building community. And when people experience this, and then they mindfully reintroduce foods for the next 3 weeks, and we talk about it and they process it, there's a real transformation that happens. And I do it in large groups because it's impossible to do it in smaller groups, but there are some community resources, health coach and other things as a model. And I think sometimes people are ready for that. And if they are, then you can help them shift and feel differently with food. And then you're buying in, and then you're going to go back to that, make a small change that you think is going to be a low hanging fruit for now, and slowly work back with it. But I think community is a big piece of it.
It is huge.
Community resources and being together with other people.
And communities can live online, so we can also share a lot of
Of course,
information
it's all online. Yeah.
And when people are on their phones and they're scrolling, and there's lots of evidence around that and sharing messages that way. I did want to share one quick Less Cancer project that we did about 10 years ago with Johns Hopkins called the 9-Minute Meal that we did with their graduate students. And the reason that came around is that they did a study for how long it took to get through a Chick-fil-A line or fast food line, whatever your fast food choice du jour is. And it was always at least 10 minutes, sometimes longer. So we had somewhat of a contest with these students to develop 9-minute meal recipes, because time is always the reason. You know, people say, I just don't have the time to eat right, so I fly into here. Really, you don't have the time, because you can have a healthier meal for less, and you can put it together yourself. Now it's all about money. You need a loan to drive through a fast food place, but it is. I always thought that was interesting, and it was an interesting study, and it was, if time's the challenge, have them make a meal. You know, it's crazy, but it's faster, and it might not be as fun or as cool or whatever, but it's faster, it's healthier.
Yeah, and we focus a lot with frozen plants or have the nutrient value as fresh, you know. So breaking people down those little steps of my vegetables go bad before I eat them. Buy frozen, and they're already sliced, or
And they're great.
Yeah,
And they're fast.
Yeah, and they're faster. So it depends where the person is, and some people just don't want to chop squash, so you buy it chopped. You know, if they have access to that.
That's me.
Yeah.
Lazy. That's totally me. So I love your intervention about the community eating and connecting people. Can you share a little bit about where that's conducted? Where you connect groups of people on that? How do you do that?
That course that I just described, I basically built a Canvas course, and it's all asynchronous. So people can access it if they have access to
Nice.
a computer. And then once a week, for an hour, I open up a Zoom call, and people stop in, and I usually stay the whole hour, and everyone has a chance to check in, ask questions, get to know each other, share what they want to share in a community. And really the answers don't come from me all the time. They come from each other. And it's amazing who it attracts. I'll have people last time I had a farmer, a cattle rancher, a grocer, and often I'll have a dietitian on there, or, you know, so some people, and then other people who are 80 years old, never eaten anything but fast food their whole life, and they decided they're going to turn it around now. And so you haven't had the depth of exposure of knowledge of nutrition. And so we all come together, and everyone brings their life experience, and we come up with really creative solutions that way.
I love that.
And it's pretty, you know, wherever you are, people come from their car, or they come from, you know, now you can zoom on a phone.
Right. It's crazy, isn't it? But it's such that access is critical and life-saving for lots of people.
Yeah.
So,
And then I do provide the recipes, and people, you know, and then people share, and then 5 years of doing this, I have a backlog of recipes that people keep contributing to me. So it's been pretty fun. I'm going to have to make a cookbook.
Dr. Petzold is doing a Food is Medicine event tonight here in Traverse City. If anybody wants to be there, I think it starts at 5. I should know it. I'm putting it on, but it's at 5, and it's for about an hour and a half, and everybody's welcome, and it's free. So it is at
Common Ground.
Common Ground. Okay. And my number is
5:30 to 7. Is it? Okay.
What is it?
5:30 to 7.
5:30 to 7. And what's the address?
Common Grounds is at 414 East 8th Street.
Okay.
So we are just kitty corner across the street from the Governmental Center at Portland.
Great.
It's actually a good place to park.
And
Great.
Barrett's
We're excited.
Market's helping us, and
Barrett's, yeah,
Barrett's Markets. So they've been amazing.
they're great.
And so the food should be really good.
And we're excited about it. So if it's okay, I'd like to move on to Dr. Rollin. Bill, it's great to have you here again. We always appreciate your support. Dr. Rollin is a DO here, physician here in Traverse City. And can you share a little bit about what's going on with you? Can you tell us a little bit about yourself, your practice?
Yeah, so Bill Rollin, family medicine trained. I'm from Cadillac, so northern Michigan, sort of native, if you will, and was lucky enough that with Munson's partnership or affiliation with Michigan State, I was able to do pretty much all of my clinical training, medical student years, and then family medicine residency here in Traverse City. So it was nice to be back north. I actually went to mid-Michigan for the first 3 years, and it really one of my first big things as a family medicine doctor was when I went Elma, St. Louis, Breckenridge, kind of in the middle of the state. But the first thing I was told by my hospital employer was St. Louis has a high prevalence of lymphoma. And the question was, is it the large total petroleum plant in there? And so early on in my career, similar to the breast cancer, I'm like, huh, okay, I got to watch out for lymphomas, right? So, obviously this stuff has been around for a while in terms of having these pockets of higher risk, maybe cancers. But I moved back to northern Michigan in 2002. So within the Munson system, I wear several hats. And so my first plug and joke will be I do that to prevent skin cancer in myself. Bill should do the same. But in the Munson system, I still practice primary care. But then I direct the family medicine residency here at Munson, which is really my bigger full-time job. And then just through I've been here a long time, and through my director leadership position, I now kind of work with our clinically integrative network, our physician board, if you will, which is a growing sort of, Munson group of physicians. But most of that interaction and care is directed toward patients with commercial insurance or, Medicare Advantage plans, those kind of things. But I've never not worked in a clinic that wasn't really an underserved sort of clinic where a high number of our patients are either Medicaid. So for us at the residency clinic, it's probably 30% any given day or higher, and then still uninsured, even with Affordable Care Act and all that happened. Yes, our uninsured folks went down. Then we all know we have a lot of folks with insurance who can't afford it, or can they afford any of the things that we're trying to offer them just because of their deductibles and their copays and everything else. So I do quite a few things within the Munson system.
And we're always glad to have you participate with us. Can you tell us a little bit about the mobile clinics, the outreach, and some of that care that you're involved with?
Right. So we are lucky in that we partner with Traverse Health Clinic and FQHC across the across the town at the airport. But we have started a street medicine outreach program in northern Michigan for our unhoused, unsheltered population, which is relatively sizable in Traverse City proper, but really in northern Michigan. And I think the kind of the central corridor through northern Michigan, like Cadillac up to Traverse City, what we're learning is that for those who are unhoused, unsheltered, there's more resources here. So more of that population of patients is moving to this area. So we, before COVID, so one of the few things that actually survived and thrived during COVID was our street medicine outreach program. And we were able to, through grant funding, get a mobile clinic. So it's basically like a makeshift ambulance that's a clinic on wheels. We have several areas within Traverse City that we go out to on a daily basis, but we're almost daily basis. We're in the process of expanding that outside of Traverse City, but still within the Munson Healthcare sort of service area. So we are certainly reaching a number of folks who are not connected with primary care. But I would say with an eye on cancer prevention, this is still a huge gap because the majority of those folks need to be connected to a primary care. The only cancer prevention thing I can think of where a patient might be able to schedule themselves would be a mammogram now locally. But anything else, you need a provider to make that referral. So we do a lot of acute care. We try to do some chronic care management, but to say we will be able to increase cancer prevention screening, I think with this population is a bit of a stretch. There's really, within Traverse City proper, there's really only 3 clinics that all of these folks that we interact with, we could try to get them connected to. But even then, we still have an issue, transportation, et cetera. I would also throw another challenge, even like if you look at colon cancer screening with colonoscopy, if you have Medicaid, if you were a private practice provider, and I referred you, my patient who has Medicaid, to that provider for colonoscopy, good chance they'll want to do it in Kalkaska, because Kalkaska is a rural health clinic, so there's an uptick on the reimbursement for that. So even for me taking care of a Medicaid patient locally for a colonoscopy, sometimes it was they got to go to Kalkaska, and I would have patients not do it because they can't get there. So there's still a number of barriers that exist, not only for our homeless, unsheltered population, but just for the folks we care for in general.
I find our main office is in a rural community in Virginia. And when I talk to people or listen to them about their challenges with screenings, they often say, getting to a screening is like enough of a challenge. If something's wrong, I don't know how to get treated or where to get treated or how I'm getting there or who's going to put these pieces together. So it's an ongoing challenge. We're in a time in our lives where we need more support, more roads, more channels to getting care, not less. And so an organization like Less Cancer, it's basically funded on bake sale money. We are challenged every day with people who reach out to us and say, can you help me connect the dots? And in theory, we're supposed to say we're an education organization. But the reality is we're a helping organization and a listening organization. And we try to help people where we can and when we can connect the dots. And that's the biggest challenge here. And I'm also curious about those people that don't live in Traverse City that might be coming from the UP to see how's that work?
From a homeless perspective?
Yes, homeless.
Yeah, no, I think if you don't have a program like ours outside of Traverse City, I don't think they get any care.
Right.
Yeah, so we're one of our outreach now. We're going to go to Cadillac because there's a pretty good population there, pretty good sized population there. So we're trying to figure out where is the best bang for our buck, so to speak, to be able to go to have a mobile clinic set up. But we also understand that there's going to be folks out in pockets and in encampments that may not be able to get to our mobile clinic. And locally, we would go to the Pines, for example, when our homeless folks were tenting there. But I think there's still a gap there.
Yeah. Do you have any language barriers that you have to address? Do you have translators? And what do you think the ratio is for non-English speaking?
Yeah, I mean, it's less. I mean, so, we're certainly less diverse population than Southeast Michigan. But for us, at least in our patient population, the 2 biggest language barriers would be Hispanic and Ukrainian or Russian. I think my clinic has had plenty of years of understanding that there are cultural barriers as well, in addition to language barriers. And we've had to be purposeful and intentional about finding folks within those communities that are trusted,
Right.
that then tell us or teach us how do we better communicate with that patient population. That was also true or is true of homeless population. Our medical outreach in that group would not exist if we hadn't partnered with Goodwill Industries and the folks that are already on the ground doing the non-medical work. But anyway, working through cultural barriers, language barriers, whether it's with family interpreters or ODI, which is the system we use as an interpretation service.
It's
a barrier.
It is a barrier, and it's different in every part of the country. In Virginia and Culpeper County, for instance, a large farming community, they have translators mostly for Spanish-speaking people, but because of the farming community. And now they have dialects they can't even translate from different countries. And so that challenge is becoming greater. And then when Kelly was talking about the agricultural piece and the people working on these farms getting sick, they don't really have any kind of health plan in place, nor is there a place to take care of them. So connecting all these dots is really important. If it's okay, I'd like to just jump around to questions. I know, Nancy, you must have a question or two.
Well, I have a few thoughts.
Yeah.
A few questions, but I'm Dr. Nancy Smith. I've been a physician around here for a long time, primary care. I also have a fellowship in lifestyle medicine. So I went through the American College of Lifestyle Medicine, which was pretty cool. Just a couple thoughts. And so my son is actually moving down to Wayne State to go into a master's program, and his big problem is access to food. He says there's literally nowhere near he's in the central business district, nowhere for him to really shop. So he's going to have to get in his car and drive to a suburb to go to a good place to get fruits and vegetables.
What about Whole Foods at Detroit Medical Center? Has he been there?
No, but it is. But if you think about the average person who has difficulty with access,
Right.
if my son's saying, well, I might need to get it delivered, or, at least he's got those abilities. He's got a
Right.
car, he can
Yeah.
use transportation.
But
But I was thinking about that Popeyes as well, because that's what you drive by, and that's people walk to.
that's what's
Yeah,
there.
they don't
And
have
the Whole
pictures, yeah.
Whole Foods there is a little bit interesting. It is about I don't know, maybe 15, 16 years ago.
Yeah.
I was having a conversation with a guy who used to run Children's Hospital, and because we were watching this family pick up everybody's got a cigarette. There's fast food in the car, and they're picking up this child with no hair on a porch. Like, makes no sense. I was like, where are they getting groceries? And did you ever think about having a grocery store nearby and possibly a nutritionist to help? Sounds exotic, but that Whole Foods is kind of interesting. And a lot of, they do have organic foods there from urban gardens that are monitored in a different way than the USDA organic. It's an interesting model, but it's a challenge. And your son is right. Like, you have to know where this Whole Foods is. You have to really, he's just gotten there, right?
Well, and his bend is urban planning. He
Yeah.
wants like accessible neighborhoods, walkable neighborhoods,
Yeah.
places. He was in Amsterdam. He said the best part was you could walk to a little local place and get all your food for the day. And you could do that every day and just pick up what you needed. It didn't go bad. It was fresh. Those kinds of things.
I think Detroit was like a #1 food desert, maybe 12 years ago, 15 years ago.
But my view on it is we have to work on the homes and the schools with the kids and how they eat. Because if the kids are eating better at school, they'll tend to gravitate more towards those things, and even in the home. One of the big things I always used was Forks Over Knives. I thought it was a great 2-hour. People are a little bit lazy when it comes to some of this stuff, but so you put them in front of a TV for 2 hours watching Forks Over Knives. I had more people convert to veganism for not necessarily forever, but hopefully for like at least a protracted period of time, or make changes, which is really interesting. When I work for the Veterans Affairs, and I have to tell you, I've never met a sicker group of people. We have literally new cancer diagnoses that blow your mind on a bi-weekly basis. It's unbelievable. And the exposures they've had certainly in the military, but also lifestyle choices in addition to that. And their challenges are traveling, So some of the stuff that we've been fortunate enough to do is have community care where people can get plugged in locally, because before they were just driving all over the state. And
we don't really understand people's landscapes to choice. Like, what does a choice mean? Like, it's in our name from 20 some years ago, but the reality is it's what the option is, where they're coming from, what their understanding is, what their culture is like. It's different, and it's different for everyone. So it's not just like a lifestyle choice. Sometimes a lifestyle choice for many of them would be having a roof over their head or any kind of food. So conveying that and trying to reduce risk among those populations is especially challenging. I know you're great at it. I know you're doing a great job.
I try, but it's interesting when you're in these, like I'm in Benzie County now, and you go to somebody's house for a party and you're like, there's nothing healthy.
Yeah, no, it's a culture.
And that is, contributes to all of this as well, including obesity and just a million different things. So it's a huge challenge. And, I think that really starting with the kids in the schools, if we could get the school systems to provide really good food for kids, that would be a huge.
And also too, with all these providers here, when patients are in the hospital, this seems so crazy because you guys are so overstretched. There are so many little micro opportunities to educate a family. Just briefly, as Tricia says, when we share information, we can lower the risk. It's not always by a lot, but there are opportunities to educate whole families when they're in the hospital. So thanks for that. Does anybody else have any comments or questions or thoughts or anything they'd like to share? Anything buzzing through the head that you're like, yeah, I wonder what that means? How about anybody up here? Do you have any more thoughts or things that you would like to share? Anybody?
I can add another piece. We kind of talk about, cultural, but then we touch on personal sort of beliefs. I trained in Western evidence-based, medicine. But I feel like my job is to be open, to, the patient that's in front of me, and kind of trying to figure out where they're coming from. Even if it fundamentally sort of disagrees a little bit from where I'm coming from. And I think the benefit we have in primary care is we form those relationships with patients that affords us to do that over time. Now, I also have very good friends who are primary care doctors. That's not how they think. Like, this is what I'm recommending. If you're not going to do it, go find another provider, which, I kind of fundamentally disagree with. But I can give a good example of, the challenges to cancer screening sometimes when somebody's like, I don't believe in any of that stuff. I know my body. I'll know if I have a problem. That's when I'll come to you, right? And so, a colon cancer example, once they hit the age of the recommendation, every year having the discussion, nobody's going to do that colonoscopy on me. And then what about Cologuard? Oh, that's just a conspiracy. They're in with the scope people. And so they have all these false positives and they're going to make money. And then you still got to send me for a scope. And finally convinced them to do a Cologuard. It was abnormal. So then, let's get you set up for that colon. I'm like, oh, I guess it was abnormal. He's like, I told you. Bottom line, this patient had a colon cancer that we got at its very earliest. And they will very, very likely survive. I mean, they are going to survive this. When it's treated, it's cured. But I don't know what to say about that other than, again, being persistent on, and then meeting people where they're at, and then trying to figure out how can we find common ground is really important. But it's hard to do.
But it's hard to do, but you also don't want to be so overly empathetic that you lose sight of what the goal is. We frequently hear from people that share their medical information with me and their suspicions. And, I just want to say, I too have been to 8th grade. Like, that's why we have experts. That's why we have science. That's why we have people with degrees. Why these providers work for years and years and years, not to spread rumors, but to share science and make it understandable to you. So it's exhausting. And sometimes I just get really frustrated and say, yeah, I went to 8th grade too. Like, woohoo.
Well, I think we need to also acknowledge this person, the expert on their own lived experience.
Yeah.
And that's an important piece of it.
Yeah.
And so to honor that and to empower someone with that knowledge. And I hear you. And I make these recommendations because we see a lot of people in your situation and some of them do have colon.
Yeah.
And so, that's great.
When they bring their horror story, my neighbor had a perforation, blah, blah, blah,
Right.
And then it's like, then you have to give them statistics of like 1 to 2% of any issues.
I bring my own horror stories. I tell them about any number of people in my family that didn't make it, and I wish their outcome was different. And I also talk about the whole idea of breast cancer was really a trauma response for me. Like, does everybody have to get cancer? Do we all have to go through this? Is this our plan? Because I think we could do it a little differently. And in fact, in 2001, I went all over the United States on my own coin, speaking to scientists, real scientists that were really good. And one of them was a Dr. Ronald Huberman, who they discovered the non-killer cell in his lab at NCI. He was a founding director of the University of Pittsburgh's Hillman Cancer Institute. Super smart guy, says one word a year. So I go into his office, I blah, 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 and he's just staring at me. And I was like, does any of this make sense or am I nuts? And he goes, no, it makes a lot of sense. We lose 500,000 smokers a year to cancer. Like, it is preventable. We don't need to lose those kinds of numbers. And so, I appreciated that. Yeah, I appreciate that as an endorsement. And then he said, we need people just like you to have these conversations with everyday people just like you, because we are terrible communicators. We don't know how to get this word out there. And so he was very helpful in instituting us in the very beginning. He's sadly no longer alive, but a great, great man.
You're fighting billion-dollar companies that are advertising and have more influence.
Yeah.
Like this stuff, right?
Yeah. All of
5G and, you guys could probably speak on cell phones and the exposures. And the,
I don't, you know, it's funny you bring that up because, but you know, that we don't do this issue in our work. We don't deal with cell issues or anything because it's so, and it's so important too in rural health to be able to get information and contact. So it is conflicting. I was always curious about the fact that it comes with a warning in the directions that says don't hold against your head. I was like, who can read this and who sees this? Like it's this small, you know what I mean? And so we don't really get into these things because I'm convinced with my little background that we lose more people to things like obesity. We lose more people to, you know, and there's a doctor by the name of Graham Colditz who's now at WashU in St. Louis. He was with Harvard. He did the nurses study. He believes cancer prevention starts when children are very small, and it has everything to do with food. He's all about the food on that. And when you understand obesity as a cancer risk, it brings you a little bit more information. I'm no expert.
no, I agree with you.
I'm just pointing to what he said. So anyway, does anybody have any questions or anything? I'm so glad everybody's here for this conversation, and glad some community members are here, and thanks for being here. And if you guys have anything, please let me know. And you can always reach out to me. Go ahead. Yay. Sure.
So all this prevention talk, what is something that you guys do personally as your prevention that you strongly believe in?
What do you guys do to lower risk? Go ahead.
Like for myself,
Yeah.
I mean, the things I recommend and try to do myself are don't smoke. Obviously, that's a big one. Try to limit alcohol. I do drink, but I try to, you know, keep it to a reasonable amount. And obviously, the safest amount we now know is none. So that's true. And then the things we've been talking about. I mean, trying to stay active, maintain a healthy body weight, and eat good food. So those
You're an
are things I try to do.
exerciser, aren't you?
I try to, yeah.
Yeah, you can tell. You're running. You're doing something. So that's great. That's good. I like the fact that you mentioned alcohol. We were really the first panel on breast cancer and alcohol use in for the National Cancer Prevention Workshop. And people wrote me hate mail because I was like, listen, I love Maker's Mark, but it is what it is. And
Yeah.
there is no safe amount. But yeah, no, that's great. I appreciate your comments. Kelly, do you want to say what you do to stay healthy?
Yeah, I will echo that. I mean, the top 3 preventable causes of cancer are tobacco, obesity, and alcohol consumption in that order. So those are very important tools, right? Being physically active and having a healthy diet, promoting a healthy lifestyle. I also think HPV vaccines, we haven't talked about that. That is a preventive strategy.
And significant.
Very significant. And if you look at rural cancer disparities, it's mostly cancers related to tobacco and preventable cancers by screening. So cervical, colorectal, those are big disparities in rural areas. Tobacco use is higher in rural areas, and also lung cancer screening is much lower.
And if I can just add to that, there's a synergistic effect, like layered on risk. So, you know, if you smoke, you drink, and you are struggling with obesity, that's like the atomic bomb of, you know, I mean, so those synergistic risks are something to be mindful too.
The U.S. Surgeon General report that came out earlier this year on alcohol and cancer has really good information and really great infographics. And one of their infographics talks about some of the biological mechanisms. And one of them is the increased absorption of other carcinogens when you have alcohol exposed in your mouth, because oral cavity cancers are one of the strongest linked to alcohol. So,
which also is connected to the HPV thing, which is, you know, it really is like very connected.
Yeah.
Trisha, do you want to tell us what you do?
Sure, I'll throw myself into the report. I love physical activity, so I think that's one of the things we have the most data on is that physical activity and exercise prevents a lot of chronic disease, lowers inflammation, and I would echo everything that's set up here. I think one thing that I find with patients and with myself is that if we want to heal, if we want to prevent disease, if we want to lower inflammation and support our immune system, being in a mind body state of the parasympathetic nervous system or restorative rather than in fight, flight, or freeze all day. And with that phone, with our jobs, with life, it's hard to get out of fight, flight, or freeze. But the human body was never meant to heal or prevent disease in that state. We're intended to survive. And if it's someone chasing us or life, the physiology in the body is not that different. And so what I do is I teach a course to my patients called Mind Body Bridging to help them identify when they're in fight, flight, or freeze and how to shift in real time into this other mind body state. And I've got a med student who's taking a year off to implement it in our local school systems because a lot of kids get overwhelmed by the world that we're in right now. And there's a lot of difficult situations, but when it comes, how we respond to them is part of what creates disease. And so that mindfulness piece, but really understanding how the mind works and being able to identify when it's spun out of control in storylines and you're seeing the world through those storylines versus responding to the world as it is, has really been a shift in it's changed my life and it's changed my patients' life. And it's always like, why do some people respond and heal and other people don't? And that's really been like my focus, my work lately is there's something different about how people present. And there's lots, it's complex. There's lots back there, but there's also, how do you take them where they are right now and move them forward? So that mind body bridging piece has been a huge shift in.
Kelly mentioned earlier that's so critical, but she said, I'm not on social media. And I thought, God, is
I'm
she
praying for that
lucky?
day.
She's the luckiest person on earth.
No,
She is the
We need
luckiest person on earth, but it speaks to that fight or flight thing because I do, there are days we might have 1 million interchanges with our different platforms. That's exhausting.
Yeah.
And so I think, our phones and these external stressors that we have in our lives of responding to the alarms, reacting to the news, whatever it may be, that I think that's a super critical thing. And sometimes, to get to that place that Tricia is speaking about, it can be a process of exercise, I think, right?
exercise is a good way to complete that stress cycle.
Right. And so
Crying is, laughing is.
I don't know. I think Pilates
I
really
like
just,
that.
No, I
Yeah.
think in medicine, it's the biggest lesson. Setting boundaries, know when to say,
Yeah, for work and personal and for your phone. When do I allow myself access to that and when do I turn it off? I know Bill never turns his off. So
no, I go to Pilates and my God, the trainer takes it away.
yeah, that's
He
true.
puts it in the locker, and the locker's shaking across the room, and there's it's off limits, Bill, and I do that, and so it is.
That's great.
It's tough, but if I don't keep up with it, then I'm behind, and I have to set alarms to take breaks, and I'm nowhere near Trisha's moment, but. Nowhere near
Yes, I'm not-
yeah,
it's
but
not-
I'm working on it.
It's not
Bill,
a
can you tell us what you're doing?
Yeah, sure. Well, I was adopted, so I didn't know any of I only know half of my genetics, if you will, now. But for most of my adult life, and when I got into medicine, that was always kind of, okay, I don't know what I'm working with, right? And then I also grew up in this incredibly conservative Christian home, where anything that was fun to do was really taboo, right? But when I got married, my wife's uncle was a mortician, and his business card said, "Thank you for smoking."
Oh,
So I've never smoked. But then my son was 24. I remember this distinctly, probably when Kathy was teaching me how to do OB when I was just a young rider, but I was chasing him around the yard and I was probably 30 plus pounds heavier than I am now. And I'm like, okay, it's time to reset, So that's when, kind of going through my your busy education and medical life. It's like, how do I get exercise back in? And so now that's just been part, it just has to be a goal. It has to be a priority. It has to be part of your lifestyle. Definitely alcohol in moderation. I didn't drink for a long time. And then somebody introduced me to what I would say was good beer. I'm like, oh. And, IPAs are not low calorie.
Yeah.
But then I figured that out because then as the metabolism slows down, it's wait. So you just got to make it, and personally take time for yourself. Make sure you're getting your own cancer prevention screening test done. It's easy for any of us to let things slide. So yeah, I just got to take care of yourself and stay consistent.
Can I just add one thing too that I've been
Add,
doing more recently? There's not as much evidence for this in the cancer epidemiology field yet, but there's a lot of interest in sleep health and how sleep influences cancer risk. And you think about how alcohol influences sleep and how physical activity helps with your sleep. So there's a lot of plausibility of the role of sleep. So that's something that I've started to prioritize a lot more. It's really hard having middle schoolers where they have to get up at 6 a.m. and they have activities till 9 o'clock at night. I'm in bed before my kids most nights now because I'm just tired and I've started to prioritize that. So I think that's something that there's more interest in. Not as much evidence necessarily linking it directly to cancer risk, but I think it's something that there's more and more interest in the field.
if I don't sleep, I make no sense. It's really, it's,
You need a lot of sleep.
yeah, it's really good. Anybody have any questions?
Is there any statistics on hydration, water, and like colon cancer? I mean, like specifically statistics on it. I mean, I know everybody's like, oh yeah, you have to stay well hydrated. It's obviously better for your gut and all that kind of stuff. But is there any definitive information out there, Dr. Ward?
I'm not aware of anything linking it to colon cancer.
Hi there.
I think it's so cool that the American Academy of Pediatrics released new guidelines like in 2022 or 2023 on like childhood obesity, like the new like way to prevent and then just like treating the child. And in the 90s, they used to do the calorie deficit and exercise and okay, blah, 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 okay, go. But now it's like an immediate treatment and you treat the whole child, you treat the whole family, and it's like a nutrition based, like there can be a nutritional referral, there can be like even the GLP-1s, there's a whole like, you can throw everything at them and it's like right away. It's not a, we'll talk about it later and like a small educational, okay, go. And I think it's so cool that Trisha's so far ahead of the curve. Like she is doing the thing before the guidelines are even released.
Mhm.
And the research for the guidelines was like this really, it was really stringent, like 16,000 trials. And like, it's just cool. It's just, I'm just,
And there's probably a couple people in this room that could speak more to me, but we do have some culinary medicine happening in Traverse City. You know, through Groundworks, same kitchen that you guys are going to be at. Paula Martin, I've worked with extensively through the residency. And one of the grants we've got now, it was also with medical education in mind, trying to bring in medical students and residents and practicing providers to get more educated with culinary medicine, food as medicine. So, but I think if you think about the development stage, I think Traverse, we're probably still maybe toddler-ish, you know what I mean? Where you might be well into your teen years in terms of your maturity of your program or even adulthood. But so I think we got growth there in Traverse City, but it's there.
Small world is that Paula Martin was out in Salt Lake City at the University of Utah this fall and told me about Groundworks.
Gotcha.
So that was great.
And meanwhile, I reserved it, talked to Paula, and I didn't know that they had already talked.
Things happening at the same time, but she was great.
I know.
Yeah.
The universe was at work, as
She's
they
part of
say,
this
right?
Teaching Kitchen Collaborative as well.
Awesome. Yeah. So I hope at least locally that will continue to get traction.
That's exciting.
You know, our clinic has participated in a fresh fruit and vegetable program for those with chronic disease and lack of means or lack of access, where they can go get some education and then get coupons for the farmers market locally to shop. And then part of the education is how do you prepare the food, can the food, all those kind of things. So, but I think we got a ways to go locally. I mean, from a generational perspective, you know, I grew up drinking soft drinks, right? Because that was, and I still Diet Coke or Diet Dr. Pepper. My kids all drink water. Like, what's wrong with you guys? What? And then all of a sudden, my youngest started drinking Diet Dr. Pepper, and I thought, oh no, I've rubbed off in the wrong way. You know what I mean? But I think at least my kids' generation, they grew up drinking water, which it'll be interesting to see if that changes some of our health issues as we move forward here. But
Amazing. Anybody have any thoughts, any questions? And hey, Kathy, I didn't see you sneak in. I wanted to, before anybody goes anywhere, Kathy Larea is an amazing leader, and she's been a great help to Less Cancer, from everything from coming to DC to helping provide these workshops. She's such a big thinking, make it happen person. We're grateful as an organization for her leadership and for the great work that she does here. And same with Heather, who's been in contact with me 100 times a day. And she has been great. And all of Munson has been spectacular in helping us have these conversations here. And of course, Michigan State has been really wonderful. They've reviewed all this content and they're providing the CMEs. So before we close, though, is there anybody that wants to jump in? I just feel like, and if you don't want to ask here, you can always reach out to me, Bill Cousins at lesscancer.org or info@lesscancer. And, reach out anytime if you have any thoughts or questions or in a way that you want to participate. And tonight, we hope you come to Common Grounds. It starts at 5:30. It's free. Trish is going to talk about food. Bring your friends. I don't know if it's an endless buffet or if some miracle's going to occur, but it's going to be a great conversation. I wouldn't go there for your main meal, but we're going to learn a little bit about food and we're excited about it. So I just want to thank everybody for coming and taking this time. I know time is not always a shared priority, and I'm so grateful for each of you being here and asking great questions and being part of this, and to our panelists who are rock stars at not just making people feel better, making them healthier, but saving lives. That's a powerful thing. And Nancy, of course, we've always loved having you here and seeing you here. So thanks for everything. So
We do have the sign-in sheet back here for CEUs as well as the instruction sheet.
Yeah.
If it's interested.
yeah,
There's flyers back here too for the Buddhist medicine, and also we talk about the event tomorrow.
oh, space that event totally. Like I don't have enough to do. We have thanks, Heather. We have a concert tomorrow at Mount Holiday. It's free, 12 to 3. Drew Hale is playing. They have great food. Hopefully it won't rain this year, but if it does, we'll still eat and listen to Drew indoors. But bring your families, bring your friends. It's a great situation there. I love Mount Holiday. Does everybody here know Mount Holiday? You do, right? It's like Little Rascal land for adults. It's like they got the head fort and all the dads there building stuff. I love all of it. So anyway, it's really a fun situation, and I love that organization, the people, and this place in Traverse City. Always such an awesome place, all of it. So thanks everybody, and thank you guys.